Good morning, everyone. Welcome. We're going to go ahead and get started. This is the Thursday, July 24th meeting of the Finance Planning and Investment Committee. Welcome. Glad you were all here. I'm informed of no citizens wishing to address the committee, so we will move straight to the approval of the minutes from the June 26th meeting, and we need a motion and second on those minutes. I have a motion from Dr. Casey, second from Tim. Any question or discussion? Not all in favor say aye. All opposed, same sign. That motion carries. And now we have our master facility construction plan. Good morning, Mr. Yar.
Good morning,
sir.
Okay. This is a very high-level update of activity around the master facility plan. First project up is the Psychiatric Emergency Center. Very near completion. As you can see, we are targeting a go-live the week of September 15. Activity by the team and planning open houses, et cetera, but everything's going according to plan. Any questions?
When's the ribbon cutting going to be on that?
To be decided.
Okay.
There's teams working on that. I don't think it's all official yet.
All right.
September.
Sometime in September. Probably the first week or two in September.
I'm hoping, yeah.
Any other questions on the PEC? I see there's fireworks coming out of the top. I think Zelia's up there. Zelia's letting people know she's just about ready. It's getting really, really close. And it looks great. All right.
Next project up is the new parking garage. Work progresses according to schedule. 90% of the topping slabs have been poured. Signage plan is being reviewed and starting to order some of the wayfinding, all working towards that go live in spring of next year. There is another subgroup that's doing the planning and communication planning around the parking shift, as that will occur with the new deck opening.
Still on schedule and
We're
within
on
budget.
schedule and within budget.
Early.
And early, so that's good.
Now,
Questions on the parking garage?
We know that you made a point, say, in budget.
In budget.
I do wanted to also make you aware that we are currently out for an RFP on the Women's Health Center that will occupy the first floor level of this garage. That's out currently, and we'll be bringing that contract forward next month.
Is that, in terms of the architecture on that, Brian, have we had to change the footprint for what would ultimately be the retail portion of space down there as a result of the women's center? But pretty much going to be the same area that we've always contemplated?
It is the same.
Okay, good. Questions for the parking garage, first floor, et cetera? All righty.
Okay.
Next.
Next project is the MOB. We are wrapping up schematic design. Just missing a few signatures, but all the departments, divisions have reviewed and signed off, and we'll be kicking off the DD phase next month on schedule.
So let me ask you a question about this, and it really is more of a procedural question. The process that you all are using in schematic design when it comes to bringing input from physician groups and employee groups, tell us what that looks like and how we as a board can be assured that there's been input at every critical level when it comes to the design piece.
Absolutely. So specifically with schematic design, the ultimate goal is to get all of the divisions, departments, services that are going to be provided, each have their own meeting, walk through the space layout, number of exam rooms, number of procedure rooms, workspace, patient waiting room space, check-in. That's all done by those specific departments, divisions.
Okay.
And then it's just wrapped and fit into the exterior of the footprint of the building and map through the flows. How do people come in? How do they get to the check-in desk? How do they work through the department, receive services, and out the door? So all of the departments that are within this building have had their own specific meetings relative to that. And as we complete that schematic design relative, to total square footage, total number of exam rooms, et cetera, they sign off on that, which is what's occurring right now. And then the next step, same groups, maybe different individuals, we'll get into that DD phase, which is where do the glove boxes go? What is the casework within the room? Or where's the sink on the physician's left, physician's right? Those discussions all occur at this next DD phase. So we're in agreement on the size and the program for each of the departments.
And I would just add,
Would you, I'm sorry, would you, maybe Dr. Davis have
Yeah.
anything on that end?
yeah, I would just,
I would say this has been a highly collaborative experience. We have had not major concerns, but sort of high-level conversations about specific layout issues, programmatic issues that are within scope of what we currently do, but making sure that we're scoping this design to look for 10, 15, 20 years out, trying to read the tea leaves of what we would actually be doing.
Sure.
But designing this in a way that allows us to do that. It has been a refreshingly collaborative effort. Really responsive feedback. We have not structurally changed the floor plan. I mean, absolutely fitting it into the modular structure that allows this thing to get built. But to meet the needs of what we will need across, for me, 10 medical specialties plus endoscopy space has been great. Very responsive.
and I would also add, we also have to include GME in everything that we do as well. And so Dr. Elliott's incorporated into these design meetings too, so we can ensure that we have spaces for student learning. Dr. Assad and Phyllis both representing the physician and the nursing component, and then our ancillary services, Joy, all have input, ensure that their teams are present. Obviously, the chairs have been very involved along with their teams with the MOB as well as the hospital.
That's great.
And very wisely done, because we opened it up to a whole lot more than the chair ever wanted.
Yeah, oh, no,
So the looking part of maybe a little bit, but right now it's, done well.
been there, done that.
Dr. Casey, how about you?
Thank you, Chair. No, I think from a common start, we're in a different path with regards to GME, attention with regards to these certain conference rooms and other things that we have in the current building, this transfer building.
Great.
There's a lot of opportunity there, for community conferences, a lot of things we've always wanted to do. Highly.
And that'll come at the time of the tower, right? I mean, in terms of,
Correct.
we really need some teaching spaces and stuff.
Yeah. Well, part of what we want to, those that don't read history are condemned to repeat it, right? We didn't do the greatest job of engagement when we built the last building at the pavilion. There was a lot of design elements to that immediately revealed a lack of engagement. And that's what we're trying to avoid.
And I think, speaking to ours, but from what I understand from other chairs, the engagement has been very high.
Good.
Speaking to part of the pavilion issue, there will be no more bathroom gate in the MOB. It was multiple comments, making sure we have enough bathrooms
Good.
in the MOB space.
We put outhouses around it.
Jill, Brian, have you all, as a result of the collaboration and the input that you're getting, and maybe this is still prospective to come, have we changed our thoughts about how much space we finish out versus what we don't finish out and what's going to be available based on this engagement? Are we learning new things? Are we potentially changing the overall initial idea?
I think somewhat. We know what our current capacity needs are, and so whenever we engaged our previous consultants like Guidehouse, they helped do some of that projection from a space perspective. I think the other part that we're layering in still is really around how much will be telehealth and really will be outside of these walls and brick and mortar, and so I think there's still a lot of work to do in that regard, and not just JPS. I think we're all struggling or trying to figure that out, what the future will hold. We will have net new exam rooms in the MOB, so if you take everything from currently that's moving into this space, it's around 50, 60 new exam rooms, net new in the MOB. And so we are taking that into consideration. You know, the hospital, you know, is a little obviously different from an actual capacity standpoint on patient rooms that we'll be talking about in the future. Do we shell anything out? Right now, doesn't look like it's a great idea to do. We're probably in July going to have the highest ED volume ever on record, and so we know this capacity is not going, you know, the capacity constraints are not going to ease up on us with the volumes that we're seeing in our emergency department, as well as our ORs, because the more cases we do in the OR, we know we need more rooms to take care of them, right, after their procedures. And so as we're optimizing throughput in the operating room as well as increasing operating room capabilities, those needs for inpatient beds are going to continue to rise.
I will just add something additional. Thanks, Jill. If we could add another floor on that tower, on the MOB, it would be probably the best decision, but we do know that we're within a budget. We would love to have a building in which we did have shelf space for future growth, you know, and as Jill has outlined there, you know, technology will come into play, and so having a shelf space in which you can take the future of technology that you don't know today into a new space and start to build it while you're still operating within that building would be ideal. But, I mean, I think that's true across. We probably would like a third tower. We probably would like a lot on our wish list. But right now, I think that the teams have done a great job in really optimizing and looking for kind of future efficiencies and technology to help, you know, care.
So Brian, when are we thinking that there will be basically a complete design that you're ready to go out there and start looking at construction contracts?
So we are actually going to the market at the end of this SD phase. Okay. So we're, as the SD gets signed off, we pull a package together. As you're aware, general contractors have already been selected, but they're taking that package out to the vendors, public, and receiving bids to get that actual feedback. Because budgets to date have been historical benchmark type budgets.
So we're already buying it out. I mean, we're already buying it down when it comes to.
We haven't committed much. There's small pieces that have been committed, but we want to get that feedback. Yeah. And then come back and say, okay, it's time to buy steel. It's time to buy generators. Yeah. So you'll see that coming in the next few months.
And DT, this may be more of a board appropriate request, but you decide that. I'd love for at least the committee to see that final design that reflects all this collaboration, all these thoughts and ideas, in a presentation that says, okay, let's make sure the board understands scope, budget, concept. You know, let's address the pinch points that we know we've had. If ED is constrained at 350, how does building a new tower help us with getting patients in beds with 350 a day? So part of that just becomes, I think, educating us on what to expect. But when the time is right, and is it better a board? Is that better a board discussion in finance? Because I just want to see it one way or the other. Okay. So we'll put that on an agenda then once that's ready from y'all's perspective, and make sure the board has input and understanding about that.
I think it's
just want to say one thing is that I know we look at making sure that the clinical setting is appropriate and doctors and all, but do not forget that the patients have to come into that building and make sure that it's patient friendly. Because that, we always look at the clinical side, but let's make sure that the patient that's using it, it's easily accessible. I hate this second floor. Would not like
Yeah, we will not repeat the second floor.
We're going to let you take care of that second floor. No, you bring up a good point, Dorothy, and we have had conversations. You know, George French, our leader over patient experience, is setting out with a new patient family advisory committee that's kicking off in August. And so that will be the forum by which we go and take certain questions to and things that we need input on from a patient family perspective. And so you bring up a good point, and that will be incorporated. The other comment I was going to make, to your point, Trent, around, bringing forward kind of the pinch points and kind of where we're going to settle with the MOB or even the hospital, I think we also need to consider what MFP 2.0 might look like. And so as we're, potentially finishing an MOB or the hospital, we're not done. And so we need to start thinking about that future growth or what that looks like. And so, we haven't been in kind of that order of thinking about facilities and new facilities and what the needs of the community are. But that is the evaluation that we need to start thinking about next as we're getting all these projects going and building.
Yeah, I'm sorry, go ahead, Tim.
That's just my concern. It's only it's cheapest today. It's gonna be more expensive in the future. So if we have these concerns about, are we really gonna meet the capacity, or do we need this additional capacity? Demographically, we're only gonna get bigger, and things are only gonna get more expensive. So if we think there's a sweet spot now to improve that, to at least maybe we'll never beat it, but at least get a little bit ahead of it, then I think we should at least look at that and think about that, to save ourselves money on that.
And Trent, I think that our discussion did not take place 20 years ago.
No.
When that pavilion went.
Yeah, no.
Just kind of went to a closed door.
Right.
We had discussions about a 7th floor and 8th floor.
Yeah.
And then all of a sudden, we have no ability. So I think this is a thing. For what it's worth, I really think in the process, especially with all these projects we're looking at every single month.
Good.
Well, what is Tarrant County grown by?
Even this, yeah.
This is the best
It's
place.
massive.
And we capped it last time with that pavilion, knowing that we had a future to go, and I think it was the best.
We're already moving procedures out.
I make them pay attention regardless.
Yeah.
Yeah, I will say for the schematic design, we have already built that in. Again, Dr. Elliott's been very much a part of the conversations, ensuring that she has the appropriate space for the teaching and education. So there is collaborative spaces available for resident teaching, medical students, nursing students, all the above. So that has been a really big part, because we know it's a gap right now. We don't have adequate space for that, and so we've been sure to include that in our process. Your question around ASCs and moving things to the ambulatory setting, we're already doing a lot of that. You're seeing more and more joints being done outpatient. They're going home with some PT in that PACU, setting, and they're going home. And so we'll continue to see more and more cases as appropriate and able to move to that ambulatory environment for surgery.
Well, no, part of what Blue Ribbon talked a lot about, and DT will remember this, what's the percentage of bite that we can take based on the demand? Because psych, for example, we didn't even come up with half of the beds that were projected in terms of psych emergency needs, because it was just, how do you ever meet that need? I think part of what the presentation to us needs to be is help us understand, to Tim's point, what portion of our predicted patient load are we going to be able to meet in the various specialty areas, and where do we know on day one we're still going to be behind? We're still going to be short. If something that we're doing is going to result in the third day appointment increasing by 90 days, I think we need to know that, because I think that all of us are in the exact same point that Tim is. We're not going to get very many bites at this apple. And so to the extent we can do it now, especially while we're in budget, and we're in a good place to make sure that we do it prospectively instead of looking back, it's an awfully good thing to do. So we'll look forward to you guys telling us when the appropriate time is for that, but we appreciate the collaboration, and doctors, thank you for your input in that, and I think that's what's going to make this set it apart and make it super for everybody. All right, Brian, I interrupted you. I'm sorry. And I already went to the new hospital.
It's all right. The next slide is the hospital. Again, just an update. We are at SD sign-off. We'll begin that second phase, the design development phase, starting next month. And we have already contract that's come through this group. The first enabling package has started. So we're about to begin some utility relocations. And the first significant chunk of activity you will see will be the relocation of the ambulance drop-off. That work will start later this summer of moving the ambulance bay closer to Main Street so that we can begin that excavation for the new tower.
Questions? Any more questions on the overall master facility plan? Or anything related to it? Dimitri did have a question a while ago. I'm sorry, I passed you up.
Yeah, I just have, I mean, and it may be too early, I'm just getting here, but just the, so on the, you said that the DD plans are up, they're at 100% on the MOB, right?
We're at the SD.
You're still doing schematic?
Yeah,
Oh,
the SD is 100%. We're starting DD.
So have we went out for any, are they doing, the contractor, are they bringing in their trade partners, or have they sent out early packages
Yes.
for budgeting, early budgeting?
Yes.
Okay, cool. Okay, thank you.
Other questions on the master facility plan? That does it, Brian. Thank you very much, sir.
Thank you.
Appreciate it very much. All right, that'll take us to CFO update and approval of unaudited financial report. Good morning, Kim.
Good morning, everyone. Good to see everybody. On page 16 of your packet, you'll have the financial packet, but I will show a few of the slides up here to review. June was not as strong. You might have seen it. It's not as strong as we've been seeing. And a couple of the drivers, both operating income and net income, were below plan for the month. Still strong for the year. What was driving that, as I mentioned at the last meeting, is we got our final settlement on our 25 DISH monies. That was a material hit to where we had expected DISH to land for the year. That required a $33 million adjustment to the financials in the month of June. So you'll see on the Medicare supplemental, I'll go to the income statement for you. On the income statement, the Medicare supplemental line has a $33 million negative variance. That would be the second line on the income statement. That is related to the DISH and the change in the allocation. So basically, as a reminder, DISH is a calculation based on the 23 cost report. And for the 5 safety net hospitals in the state of Texas, there's a pool, and it looks at your payments to cost ratio from that cost report, and then they allocate. There's some formulas that we're trying to get insights into. We're still waiting for the release of information, but trying to get insights into why ours and 2 other hospitals went down and Harris and Parkland went up. And this isn't something where we can go back and get the money again. We need to understand the calculation. So we are working on getting the information. It's a kind of a slow process to get the federal information in order to get cost report information, and then also from HHSC on how the calculation was done. I know that's a lot of detail for Finance Committee, though. Just understand we are looking at it, so we understand what 26 may look like, if those are impacts. We are planning on 26, and we'll talk more at the budget retreat in a few weeks about what our assumptions around the supplemental payments are.
Kim, a question. Is the negative 10.8 million accrual or cash? And if it's accrual, are we gonna have to send money back at some point?
We will not need to send money back because we got 2 interim payments, and the third is the settlement and the final, and they'll be paying us another $7 million. So nothing to go back.
So this is accrual. Is it catching us up for the whole year? Or
Yes.
Are you gonna stagger this
It's-
for the next 3 months?
It caught us up for the whole year.
So there'll be no more negatives.
Well, the negatives that will hit for the last quarter will be the DISH we budgeted to receive, which is about $7 million a month. So we will be short on our budget by about $20 million for the last quarter.
But there won't be a negative adjustment, which will be a smaller number than.
No more adjustments. It just, we will not have any recognition of that revenue. Does that make sense?
Are you booking 0 dish for the rest of the year then?
Yes,
Okay, thank you.
yes.
Other questions for Kim?
Well, offsetting that, so we can go to the positive side, and at least volumes were strong, and you heard from Jill that volumes have been strong. We are at surge 5 today in the ED, surge 6 yesterday very busy. In June, we had 19 of the 30 days at surge level 3 or higher. We are very busy organization right now, trying to cohort patients, making sure that everyone coming in is getting taken care of. We don't go on diversion. So we take care of everyone who presents. We're looking at balancing into the urgent care. We're looking at strategies to decompress some friction we might have in getting patients discharged or into rooms, everything we can possibly do. So kudos to operations and the support services that are doing everything we can around the volume. So we did have strong volumes for the month.
Can you give any explanations for the higher volumes?
I would actually ask Jill.
There's just more
She'll have
people.
better insights. There's
More sick people.
heat maybe, and I mean, heat and some other things.
I mean, it really is just new volume. We're not seeing an increase in anything in particular. This is a high volume time for us anyway, July and August, because of heat and trauma. And so we are seeing heat and trauma. We have had a little bit of a delayed heat reaction. You know, this summer we haven't hit 100 yet, and so it's been a little bit more delayed this year. But this is the typical months that we see high volume. I think back to the earlier conversation around just pure Tarrant County volume, we're just notching it up every single year. So nothing in particular we're seeing in the ED, though. I ask the same questions of our ED chair all the time. Dr. Knowles, can you tell me what you're seeing? It's nothing in particular.
It's a new normal. I mean,
It is. Yeah, just volume, population growth.
Dr. Casey, yeah. I was going to say, Dr. Casey can probably give you some perspective. 10 years ago, kind of what we saw 5 years later was considered a huge surge, and I just think it's growth in Tarrant County. Yeah, don't you? I don't think there's any relief from this. Yeah, I don't think there's any relief.
110% every day.
Which gets back to Trent's comment earlier.
Yeah.
Our design of the hospital.
Yeah, no, absolutely.
Okay, we are taking that, and we've already done work with Beck on that third tower, so we are taking this to heart, okay? Jill, are you hearing this? So pull it back out. Archive.
MFP 2.0.
Tim says move ahead. Put another floor in the MOB and another
Thanks, Tim.
tower.
So, Kim, are we comfortable that on the ad valorem row that we've budgeted for all of the conclusions of the protests? Are we pretty comfortable now that that's the right ad valorem number? I know protests are still going on.
They're still going on, is my understanding, because they're filed, they have a deadline to be filed, but they don't all get resolved at the same time.
Right.
So that, we've seen the last 2 months, I had asked last week, how much longer, because the year's almost up. So shouldn't see much more, but again, not controlling the process to settle the appeals, so.
Yeah. Well, I don't want us to miss the big picture here, the forest for the trees. We consistently are able to reduce the proportionate share of ad valorem income as a result of total net income, right? And a lot of that is volume. A lot of that is income that we've been able to get. We've got better commercial payers now. We're in much better shape when it comes to diversifying revenue streams, which has been a central goal here for many, many years, is look at how we can bring in new revenue streams. So the trend of being able to reduce the proportion of property taxes relative to the overall expenditures is intact, and we're in good shape with that. The question, though, becomes when we load all this debt in and we put in all of these new operating expenses, we need to be able to forecast whether or not that proportionate share of the tax revenue continues consistent, or whether or not we end up having to, not be able to look at that as the same descending trend that we've had over the past few years. It's going to be a very important thing to communicate, both operationally and politically, to make sure people understand where we are. And hopefully this budget cycle will shed some light into that, because we've got, $2 billion is a lot of money. And from an operational standpoint, the proportionate share of dollars that go into debt versus operations at JPS is going to change in ways nobody's ever seen for this hospital district. So being able to understand how much of that dollars is going to be encumbered into debt service versus how much is available to cover this expanding operating demand is just central to what we've got to be able to bring, through this budget process. So I know you're working on that. We've talked about that. important for us to keep our eyes on the ball for that, for sure.
Absolutely, and thanks for saying that, because we are growing, and you'll see later in the deck. The interesting thing, though, is the commercial business is actually kind of staying relatively flat. We're seeing the increase in the charity and the self-pay patients, and that is what's being funded by the tax dollars.
Yeah.
And so that's the other concern, is as the county continues to grow,
Yeah.
so does that population. And as federal changes are made, that, you know, we don't have control over the federal changes, but as those changes are made, we're seeing the expansion of the ACA incentives are going away. We expect to see about a $14 million impact alone just from those being reduced, because we expect those patients to go off of the marketplace and no longer have that commercial coverage.
Yeah.
And so, to your point, we have to balance that growing population with the mix of that growing population, along with the debt we want to take on, because we are a very thriving and growing community. And who said it earlier, this is a great place to live. I've only been here 2 months and I love it. So I think, to your point around the tax revenue, we really have to look at what we're funding to take care of the county, along with what we can get. We'll talk at the budget retreat about the managed care strategy and what we should be doing in that space. And so we'll talk a little bit more about what we can do around a managed care strategy also.
Great.
Well, plus, when you look at the political climate, we're gonna try to keep it as a balance with revenue. and
Sure,
expenditures.
sure.
Political climate has got to understand where our position is also.
Yeah.
You know,
Yeah.
if they're not sensitive or willing to be sensitive to our position, then I don't care how we work it,
Yeah.
it's still gonna be important.
And I think it's our job to make sure that we portray that correctly, completely and correctly, so that everybody understands. Because when we make policy decisions here, those policy decisions, I think, will completely be respected as long as we can back up what we're saying with the numbers that show it. And we've been blessed with, you know, a growing net income over the past many years. And that's great. For Tarrant County, it's great for JPS. But that's not always going to be the case. And those lines are going to meet. And when they do, there's going to be some hard policy decisions have to be made. So, Kim, we're welcoming you to your first official presentation as
For the budget?
committee, but also saying, hey, there's a parade. I think it's a parade behind you, but it may be a mob. I'm not sure. Just keep running.
Okay, just keep running? Okay. All right. So a couple more things on the income statement to highlight. Trent, you had mentioned the additional service lines, retail pharmacy. The specialty pharmacy is really going well, that investment in that strategy and moving forward. So you'll see that on the retail pharmacy, the majority of the variance month to date and year to date is really sitting with the specialty pharmacy and the growth there. Retail and central fill are also favorable, but the specialty pharmacy and the growth of that has been fabulous. The other variance I'd like to point out, you'll probably, if you were looking closely, you saw the benefits were extremely favorable for the month by about $12 million. We had the, twice a year, we do an adjustment on the pension liability with the actuary, and there was an $8 million favorable impact to the pension liability that hit this month. So that partially offset some of the dish impact that we had for the month. Any questions on the income statement? I'll move to the balance sheet really quick.
A comment.
Yeah.
For Kim. It's easy to focus on actual versus budget, but I like to also look at current year versus prior year in the revenue section. And this underscores what we've been saying earlier about increasing volumes. The increases in revenue year over year are impressive.
There.
And, I mean, revenue is, you know, the most important thing on the income statement, more than expenses. Expenses controlling is very important, but you gotta have the revenue coming in, and the growth is impressive.
Thank
Especially,
you.
you mentioned the retail pharmacy, up 16% year over year.
Mm-hmm. Absolutely, and that's continuing to grow constantly. So, good investment. It's actually nationally been a very good investment with health systems take that step to really service that population.
All right, great.
Let's see, balance sheet, there we go. Balance sheet, just a couple of things I want to point out. We have seen an increase in the accounts receivable. You'll see later in the deck, the days have gone up by a few. This is primarily due to growth. There is some aging of the AR going on that we are addressing, but about 2/3 of the growth is due to volume and the increased volume we've seen. And then we're looking at the aging. Aging has to do with payer behavior and slow pay. So we'll be working with the payers on what that means to us. You'll see about, in the non-current assets, you'll see the two lines that say board restricted for master facility plan and the bond proceeds for master facility plan. Those are the proceeds, that's the reserve we have for the project. You might add it up and go, I only see 1.35 million up there. Remember, when we talk about what we've contributed, we still have the second round of debt if we choose to go that, and we also added what we thought we would contribute the rest of the year. So we're about at 1.9, really, just hitting almost that 2 billion mark for where we feel the fund is today, or will be at the end of the year, excuse me. I think that other than that, I have nothing really that sticks out on the balance sheet. I know we have potentially, any questions on the balance sheet today?
Well, assets limited as to use current portion, way down from, what is that?
Assets whose use.
So look at the current assets.
Those are leases. Those are the new accounting for leases that we put the leases up there. They draw down over the year. It's just new lease accounting rules.
Why is it so down then?
Because we reduced some of the leases that we had, the future obligations. It's based on future obligation. So when they change the lease accounting rules, you have to recognize the whole thing on the balance sheet.
Those are leases where we're the lessor,
Yes. No, lessee.
we're the lessee.
We're the lessee. There's an offsetting entry on the liability side to that also.
All right, other questions on the balance sheet?
No, they're not part of the pool, the bigger pool that we are part of. You know, DT, I can't 100% answer that because I'm not 100% familiar with, but I can look into that.
Shifting what?
He's talking about the cooks.
Cook,
They won't shift to here.
it shouldn't
Those
shift.
kids will be picked up on the managed care plans that were awarded.
To the what? To the,
Yeah,
To the managed care.
But it
plan.
won't be to
it'll be
us.
shifted,
But
yeah.
that would not impact us.
That doesn't impact
That would
us.
impact us.
All those kids will just go on new plans and not on Cooks.
Our calculation does not include cook, children. You're talking about the plan? Sorry. Sorry, the shift over? I don't think that's going to impact us because we aren't at risk for our plans. If we were in a downside risk model for Medicaid, I think then that would impact us, but we're not. We can take that as just seeing what the impact is, if there is any. I wouldn't expect there to be DT, but we can take a look at that. Thank you for asking.
other questions on the consolidated balance sheet or cash flow?
The only thing I do want to point in on the cash flow is this is the cash flow for the cash, not the master facility cash. So the very first line on the balance sheet, and you may say, oh, it's gone down 124 million. What that 124 million is, if you look at the last line under cash disbursement, it says investing activities net. 300 million was moved from our cash to the future fund. And then there's another 80 million offsetting that in investment returns that have offset that. So those net together, So it looks like investing activity outside the organization, it's within the organization.
Yeah.
So I just want to be clear that we don't really have a negative cash flow on that. It's we've moved fund to the master facility or the future fund.
Yeah. Or during budget, Kim, are you going to be able to show what we've been able to accrue in the future fund master facility plan versus what we think those capital needs are going to be over the next 5 years?
Yes, yes. All right. Really quickly, I had already mentioned that this was a loss for us for this month from operations, something we haven't seen for a while in a month. If we had not seen that, we would have had a favorable performance in the teens for operating performance if we didn't have that $33 million dish adjustment for the month. I will point out that when we talk about staffing, overtime is up a little. We are managing that, but again, with all the surge activity that we have, we need to have people in place to take care of these patients. And we can't just bring people in at regular rates because we just don't have staff. It would be like staffing every lane at Walmart for maybe every customer coming in, but we can't afford to do that, so we bring them in at overtime. Contract labor, though, is down, and so that's a favorable performance metric. From a statistic perspective, all the statistics that we've talked a lot about this, our case mix was up for the month. I'm actually going to go to the detail pages. These are a little bit easier to see. We talked about inpatient, and surgical admissions were strong. Our case mix index did go up for the month. Some of that is related to we had some higher level care coming through. We had a couple of leukemia patients come through. We had some high-level OR trauma cases. We had twice as many as we normally have. To give you an idea, the case mix index, that's like 7.5 on a case mix index. And that does push the case mix index up. Length of stay, just to give you an idea on length of stay, we do have patients who stay long. We had in June 3 patients that were over 165 days in the hospital. We had one that was at 400 days in the hospital. And that's because we can't find a place for them, or maybe they're not transferable at this point in time. So we do have some long length of stays sitting in the hospital.
What's the difference between not transferable and can't find a place for them?
Not transferable means they're not medically stable to
Medically
leave.
stable, okay.
Can you repeat that again?
Non-transferable, they're not medically stable enough to leave. We need to keep them in an acute setting. All right, ED visits, we've talked about ED and the surge levels that we've had. Primary care, we have opened up access. We've continued to look at the templates and produce more access because we're seeing our practices have a huge need for new patient access in the organization. Here are the surgery statistics. Inpatient on the left, outpatient includes Jessica, the ambulatory surgery center. We're seeing volumes go up on average at Jessica. They're a little bit down on the outpatient side on the hospital side, but together we are showing an increase in outpatient surgeries for the system. And then behavioral health, we look at the emergency room. The emergency room was about on visits were about on target this month. Last month a little lower than anticipated, but the trend is there. We're also seeing changes in the behaviors of the police in the community. And we know with the PEC, it will also give us more fluid access to the emergency room services for PEC, so that we're looking forward to not having to bring them all the way up. I believe it's on the 10th floor to the organization. So it'll streamline that and better care for the patients.
When PEC opens, and Zelia, this is probably a question for you. When PEC opens, are we going to see a spike in this number?
I think maybe initially there might be a spike, but I think that given the new location and being able to access it better rather than families bringing a loved one in crisis to the 10th floor, we'll probably see an increase in more walk-in traffic. Also, we're going to have a special open house for first responders and also our EMS system here in the county, so that we're able to show them the special entrance we've created just for them. We have it's called a Sally Port entrance, and so we'll be able to open the gate automatically after they buzz. And so it'll be for police as well as EMS, as long as the patients being brought in from EMS meet certain criteria. But our goal would be to have them brought directly to the PEC in lieu of the emergency room, which will help with some of the capacity issues we've been experiencing in our ER as well.
Any just off the cuff estimate of what percentage of our current emergency visits actually would be qualified under what you're describing as PEC admissions?
Well, they transfer to us about 18 to 23 patients a day from the medical ED.
Wow. Wow.
Yes.
So that's 8 or 9%. That's a big number. Wow. So Zelia, will we see case mix index change with these admissions?
There's really not a CMI index for behavioral health, unfortunately.
No, it's only the non-behavioral health that's in the case mix index.
Yeah.
That seems wrong somehow.
We actually are working on an acuity index for behavioral health. Our nursing director, Annie Logan Klein, and our physicians are working on an acuity index, which is something that's not been done yet.
Cool.
In many areas, so we're hopeful that we should have that operational along with our EPIC team in the next 3 months. So we're excited to have that.
Great.
Zelia, and maybe TJ can add something to this, because we did look over in the Medical Home Southwest area on just behavioral health access. And would you say that there is increased access, that there's been more behavioral health access created in the community? Because TJ, I think we did see some of it in that.
That's correct, we did. When we looked at that, we kind of looked at a 10-minute drive time around the Medical Home Southwest, and we definitely saw some increased activity. So from a market perspective, that was interesting to see, because now we've got at least data to back up some of the moves that we may think about doing in that market.
So there is a response among all healthcare to increase that access.
That's awesome.
They see a bit of a spike on the inpatient side too, because if they come in medically unstable, if your volume goes up, they get stabilized medically and then come back.
Yeah.
You may see a little spike.
Yeah, that makes sense. Yeah, just being able to see more patients is going to probably have, a flow effect everywhere throughout the hospital.
Yes, it will, but ultimately, though, I think there's a subset that, the EMS takes all psych patients to the medical ED.
Yeah.
And they get an MSE and go up to the PEC. So those are the patients we're talking about that we can potentially divert from the medical ED directly to the PEC and to help with capacity issues that we're currently experiencing in our medical ED.
That's great. 18 to 20 patients a day is a big number in terms of reducing stress in the ED, no doubt.
We have about 50% of our patients come from police drop-offs.
Yeah.
And then the balance are walk-ins. We have about 30 to 35 walk-ins to the front of the PEC in a 24-hour period.
Wow.
And I really think that's where we're going to see a lot of growth.
It's incredible. Awesome. Thank you, Zelia.
Thank you.
Yes, yes, sir.
Just a comment. I think from what we're hearing, and we already knew this, but this just underscores, the opening of PEC is probably the most significant game changer in healthcare in Tarrant County in a long,
Long time. No doubt.
Absolutely.
No doubt.
It will be a game changer.
Frankly, for the entire region.
Yes.
It's a game changer for the entire region. All right.
There's nothing else like it in the state of Texas.
Yeah.
And we really appreciate your support in getting us here.
Yeah. Great job. Great job, Zelia. All righty, Kim.
To wrap it up, these are the financial goals. All of the goals, with the exception of 2, are overstretch. One of them is almost at stretch. That's operating revenue per adjusted patient day. The dish pushed it down a little bit. And then length of stay continues to be a little higher than we had anticipated. But otherwise, a great picture against the goals. So I'd entertain any questions on the financial performance for June?
Just want to point out, the left without being seen threshold is 2.5. The target's 2.3. we're at 1.8. That's incredible. 350 people a day, 1.8% left out being seen. That's unbelievable. I mean, congratulations. That's fantastic. Just fantastic. All right, Kim, anything else?
Not from me.
Any questions for Kim? Conclude the financial report. If not, we need a motion to approve. Motion for Dr. Casey, second from DT. Any question or discussion? All in
No.
favor, say.
I would just like to make a comment about just how great it's been having Kim join our team. I think this is the right time for Kim to join as we are navigating through Charlotte's Web. I mean, it really is from all levels, from the federal all the way down to local. So I do want to thank you. I've been really impressed with how you've come in and settled in and moved forward. And so thank you.
Thank you.
Just want to
Kim, it's good. It's a pleasure to have you here. We appreciate your work. I know this is like being thrown into the pool when you're 4 and told to swim, as opposed to how really taught to swim. But we appreciate the effort and look forward to the budget process and giving us some new direction.
Nothing better than taking care of people, so that's what drives me every day.
Perfect. All right. We have a motion and a second. Any question or discussion? Not all in favor, say aye. All opposed, same sign. Motion carries. Thank you, ma'am. And we will be on consider pricing agreement between Tarrant County Hospital District and, oh, I'm sorry. Oh, okay, yeah. Consider interlocal for collection of taxes. We don't want to miss that one. We need to collect taxes. All right, Kim.
We just pay for it.
Okay, this is a new contract. It's a 3-year contract for a total of just under $6.4 million. The tax assessor has reviewed where taxes were being collected or fees were being collected or not in the county for sending out bills to collect taxes. We were one of the organizations that was not paying, and there was no reason for us that they could find that we shouldn't be paying, and so we need to sign this agreement and execute it to begin paying for the annual mailing of taxes to the residents.
It was a good while it lasted.
This is, the total
you know
cost
how
over
that
3 years.
This is just 2.2 million a year, roughly 2.1.
Basically, we're paying them for their collection services.
Correct.
But it's just money that we receive for that.
Yeah.
County and we paying the county for the county taxes for which we get paid.
Yeah,
It's-
raise the taxes so we can get money.
Yeah, but the buckets matter. The buckets matter. All right, any questions on this contract? Who's going to be brave enough to give a motion on it?
I do have a question, like, how do they come up with that number?
So the number is based on 98 cents per resident mailing and $2 per non-resident mailing. And there's an estimate made on the number of mailings they do. And that's the rate for everyone.
Well, Rick Barnes is a friend of mine, I know he's not making those steps.
But they're also charging school districts.
School
cities,
districts,
right?
college.
So the actual cost to mail this bill at the county level is $4 or $5. I mean, if they're charging us just shy of $1 to do it.
I can't estimate their costs. I'm sure their budget is public, so.
Tim, you wanna go negotiate a better
I
deal?
mean, I kinda, I'm a little upset, to be honest.
We'd like to see that happen, Tim.
Yeah,
We would appreciate you going over and visiting with them.
we thought this would be a good one to start with, so.
All right, we still need a motion.
Still need a motion.
Motion from Dr. Davis, second from Dr. Fowler, is that right? All right, any question or discussion? All in favor say, if not, all in favor say aye.
Does that work?
All opposed, same sign, that motion carries. Charlie, come rescue us from this discussion.
Thank you. All right, thank you. I have 3 contracts for your consideration today. The first 2 are a result of a multi-bid for single-use scopes, laryngoscopes and bronchioscopes. It's a 5-year agreement with Ambu Inc., $1.5 million. Again, it was awarded through an RFP. Any questions?
Any questions?
It's actually more a question for the next one, but it relates to this one. Where are we, I thought the entire network was using Ambu for this. Where are we using the other one?
Verathon, I think it's the bronchioscopes. They have
We use Ambu.
it was a split spin. There's a specific procedure that we're using the bronchioscopes for Verathon. There's a cost savings for Ambu, and we've tried to switch some of that over, but we did dual source because we still have some spin with Verathon.
No, we don't. These are all disposables, right?
Single use, yes.
Yeah, I think all our interventional stuff is not single use.
Yeah,
The ICU level or ENT, I'm guessing maybe.
It was a niche that there is some cost savings to switch and standardize the Ambu, but there was still some usage for the Verathon and the bronchioscopes that we could not switch over. So that's why it was a dual source.
I guess the question is where, right?
Yeah.
But I can absolutely look into that and get further details.
Yep.
Are these interchangeable parts?
I mean, in our world in the ICU, I mean, this is a disposable scope, so as the name implies, use it, toss it. We use all Ambu up there, and across the medical and surgical ICUs, we use the same stuff. So in our world, yes. The only other world I can think that we do this in is possibly the ER, but I would think they would use the same stuff we do.
What about the ASC?
Yeah, ASC.
Could be at
whatever
Jessica.
ENT is doing in the clinic.
Yep.
Would be the only other places I could think these could be used for this.
I can look at, I know the ASC does have usage on this. I can find out specifically if that's where they're using the Verathon.
ASC too, with
Yeah,
for some of
would
their
be the other.
inpatient stuff. So I'm not opposed, obviously, to doing it. I'm just surprised we have two.
Charlie, could you get back with Dr. Davis once you get that answer?
Absolutely. And we did achieve some price savings. So it is about a $20,000 to $30,000 discount on our previous pricing with these two vendors.
And sorry, I realize again, this is Verathon, but here, we're with Verathon because Ambu couldn't supply whatever that equipment was for that specific need.
They can, there was a quality preference for Verathon to keep them on contract.
All right, any other questions for Charlie? Need a motion? Motion from Dr. Davis, second from Tim. Any question or discussion?
Is that just for the first item, or?
That is for the first. The second one is the contract with Verathon.
Okay, so this is only the first one. Any question or discussion? All in favor say aye. All opposed, same sign. That motion carries. All right, Charlie?
Great. So as we discussed, this is the second contract for Verathon, $2 million in anticipated spend over the 5 years. Again, it was a dual source through an RFP. And again, I think it's for the bronchioscopes, part of the single-use disposables.
So this kind of goes hand in hand with that last one.
Yes,
Once we get some answers, Dr. Davis would like to get
Yeah, you
that.
could send it to me, and volumes between the two, because I think that may help answer part of this as well. I'm just happy to look at it, and if we can have conversations with
Sure.
be happy to work through that, but.
Absolutely. So I'll follow back up with the volumes and the specific sites where those are used.
Yeah, great.
Thanks for doing that,
Yeah,
Dr. Davis.
appreciate it.
Mr. Chair, if I'm not on this committee, but if the committee's approving these, before we get this information, can we at least have it before the board meeting?
Oh, sure. I think, why don't we just, can we put that on the portal? Can we get that information and put it on the portal before the board meeting? Just in terms of why we're doing that. Yeah, that would be good. We can do that. Okay.
Yeah.
Yep, we'll do that, Blake. Thank you.
Okay. Thank you.
All right,
Or you
then
guys approve it?
we need a motion for the Verathon separately. I have Dr. Casey for a motion, second from Dr. Davis. Any question or discussion? All in favor say aye. All opposed, same sign. That motion carries as well. And Charlie, you're going to take us to exemption to bid on this item, allograft tissue distribution agreement, Tarrant County and UT Southwest.
Correct. This is a pricing agreement for tissue and cornea-related material from UT Southwestern. That is exemption to bid. It's a 5-year agreement worth about $750,000 over the 5 years.
So this motion needs to include the exemption to bid recognition. Do we have such a motion? Motion from DT, second from Dr. Casey. Any questions or discussion? All in favor say aye. All opposed, same sign. That motion carries. Thank you.
Thank you.
And Brian, come back up. Thank you, Charlie. Appreciate you being here today. Brian, if you can come talk about the lease agreement number 5 between Tarrant County Hospital District and Resource Connection of Tarrant County.
Yes, requesting approval to amend this lease agreement with Resource Connection of Tarrant County was for 2500 Circle Drive, which was the previous South Campus Clinic, now in Medical Home Southwest. And so this is canceling a current lease.
Ending.
Ending the lease,
Well,
right?
not the entire lease, but removing that space, because we do.
That, yeah, yes, the lease for the specific address.
So is this the South Campus space that we moved into the Medical Home Southwest?
Correct.
Okay.
So this is ministerial. This is just closing the lease agreement on this
For some reason,
portion
we
of the
gotta bring
facility.
it to
That
the
portion of space,
Yeah.
right, we're amending the lease.
And that requires board action, so we do need a motion on this one. Motion from Dr. Davis, I'm Dr. Davis, Kim Davis, and second from Reverend Emerson. I can't believe I haven't done that yet. I mean, it's the first time.
We just first and second, just make it Davis.
Just thank God you're not sitting next to each other. All right, that motion carries. Then we also, Brian, are you going to talk to us about resource connection of Tarrant County? And then this is the contract with Ramel Company, right?
Correct.
All right, if you can
Yes.
present that to us. Item G.
I'm
Item
sorry?
G, Program management.
Yeah, program management with Ramel, requesting approval for this program management services. It's a 5-year agreement, $11 million over the timeframe for the master facility plan build, providing oversight and program management for the remainder of the activity being performed. Oh, sorry, thank you.
For the committee's information, and Blake, thank you for your time on this. Dustin also spent time on this. A significant amount of energy was spent looking at all the resources that we have available to us at JPS to make sure that this contract meets JPS's needs, that it is an efficient contract, that is fair in terms of pricing. And I want to give a shout out to Bill Manning. Bill is a volunteer in this case, but probably one of the most renowned program managers in the country when it comes to aviation management. Blake, thank you for bringing Bill to us, but Bill was gracious enough to sit in with us on discussions on this contract to make sure that we are doing everything we need to. And Bill was favorably impressed with the results and has also agreed to continue supporting us with his presence and support as this project moves forward. So I appreciate the individual members of the committee that were willing to sit and listen to that presentation, and ask if you have any questions for Brian.
Not really a question, but a question. Dustin had a
Yes,
concern.
Dustin was in those meetings.
He got this concern.
He was, and told me that he supports the contract now.
We have a current agreement with them. I assume this just supersedes that agreement.
Yeah, that
Correct.
agreement will be terminated, we'll just have one.
Do we have to take action to terminate that, or is that?
No,
Okay.
no.
All right.
I have a
Yes, sir.
question. The number that we've tossed around in the past was 14 million. This is a lower number. Can you explain the difference?
This is, I think they may have been including previous services. That 14 million, that number doesn't sound.
Yeah, it's
I was going to say, I think the next highest bid,
The next highest might have been at that level.
Yeah, the RFP was 11 point something.
this is 11. This has always been.
Yeah.
And, Mr. Chair, and I was in those meetings, I feel very good about this award, and with our own team here, with Brian's team and Bill's help. I have a very good feeling about the oversight of this construction project. Very good feeling.
Well, I appreciate the committee's diligence in pursuing this to make sure that we've got all of our i's dotted and t's crossed, and I think we have in this situation. So thank you all for the extra work. So we need a motion then.
Actually, with Rawls requesting their request to move this to this point, it's a plus.
No doubt, without question. Need a motion. Motion from Dr. Casey. Second from Tim. Any questions or discussion? All in favor say aye.
Aye.
All opposed, same sign. That motion carries. Thank you, sir. And we will move now to approval of service order number 1, new hospital between Tarrant County Hospital District and Burns Engineering, Inc.
Yes, requesting approval for Service Order 1, Burns Engineering, new hospital project This was awarded through an RFP process, and it's a 5-year agreement, $1.568 million to provide technology services for the new hospital addition.
So define technology services for us.
So they are the engineer of record for our technology component of distribution for fiber wiring, et cetera, throughout the hospital.
Will that include the CUP?
Yes, it will.
It will?
Yep.
Okay. All right. Any questions for Brian?
Question.
Yes, sir.
It's more about process, I guess, because I'm assuming we're about to see a lot of these start to come through.
Mhm.
Is that, I guess, what's the detail at which we'll see that versus when are things just gonna be kind of as a package?
Yeah.
And I'm agnostic as to either, but I
Sure.
guess what should we expect to see in the coming?
Brian, how do you plan to present these? And I know we have the dashboard, and
Yeah.
so the dashboards are obviously going to expand, but how do you want to present this and what's your plan?
Well, at a very high level, we will have engineering design services separated, such as this one. And then we'll be coming forward, each project, CUP, separate from hospital, separate from MOB, will have a series of packages. So a month or 2 months ago, I brought the first package for the hospital, which was the utility location and the excavation. So you'll see 3 to 4 packages per project as we proceed through each building. Yep.
Other questions for Brian? If not, we need a motion. A motion from Dr. Fowler, second from Reverend Emerson. Any question or discussion? All in favor, say aye. All opposed, same sign. That motion carries. Thank you, Brian. Thank you. William, welcome, sir. An approval of purchase agreement between the Hospital District and Pitney Bowes.
Good morning.
Good morning.
So this contract is with Pitney Bowes. It's for $140K, 5 years RFP. We had 2 existing systems in-house, Pitney Bowes for the main hospital, or for the main mailroom, and we had Quadient for the pharmacy. This represents, through the RFP process, a consolidation, and through the rationalization, there'll be a small cost savings.
All right, heard the recommendation. Any questions?
Just see if the tax office.
Tiny little change order.
So moved.
We have a motion from Dr. Davis, second from Tim.
The Davises.
Any questions or discussion? All in favor say aye. Motion carries. Thank you very much. All right, William Gartner, Inc. Services.
Thank you very much. So we've got a contract with Gardner Inc. for $1 million over 2 years, and we've gone through the DIR for this. Gardner is a leading global research and advisory company, and we leverage them in 2 ways. One, for the in-depth research analysis, think education materials, those analyst insights, research documentation. We've pulled down about 250 documents over the course of the last 9 months from an education perspective, and about 37 toolkits just in the last 9 months. The more important is the second aspect of the consulting services, where we have the opportunity to do 2 things. One, ask an expert. So we have actual ability to have sessions where we sit down with an expert and cover everything from cloud interfaces, security, et cetera. And we've done 11 of those over the course of the last month. And then the other is the consulting services associated with contract review and bid. In that, we do about 15 contracts a month. 7 are in the queue right now for their review. But we get down to the specificity at the SKU level when we do all our hardware. So all the refresh hardware that we brought through goes through a bid review. And we've done about $5.4 million worth of contracts reviewed, as well as software contracts. And software contracts, we also leverage them for requirements analysis and technology assessment.
Are they currently our provider?
Yes.
Okay.
Will, does this contract review ever result in a better price or better terms?
It does, and it's also caught some errors. So, like I said, we go down to the SKU level on the technology side, and we've seen some errors. The numbers were transposed, et cetera. So think of them like Vizient for technology. They've got a massive database that they match the SKUs to, and they give us the analysis right back.
Is it possible that they're paying for themselves?
Oh, by all means. both in the contract services, but more importantly on the education. At Compliance Committee, we went over the risk log for IT, and one of the risks is staff education. We're about to go into a cloud environment, and we need mechanisms to be able to train folks. This is one of the mechanisms that we're using. Yeah, so we do the functionality review, obviously, before we do the contracts. So they're involved in review of RFPs, et cetera, before we move forward. The contract review is looking at wholeness of offerings. Do I have all the services, the legitimacy of the services, the cost at a high level of the services, and then if there are individual line items, the cost associated with them. Obviously, hardware is a lot easier to deal with than the services. Yeah, but they're
Who is doing DT?
class.
Class.
They're comparable, although they're a higher level of service and a higher scope of capabilities that they provide. They both review technology. They both, Gartner Gartner does the Magic Quadrant analysis on a yearly basis for each technology known to man. We do. No, I'm sorry, I don't necessarily. So we're not necessarily leveraging them as pick which vendor we should put out on notice for the RFP. What we look at them is when the vendors come back and they apply, we have the ability to look at the Magic Quadrant, which is the industry standard associated with assessment, where they stand in terms of whether they're leading or lagging for their technology capabilities. So it's more or less a first draft, so that we know what questions to ask when we get into the RFP process. It helps identify the gaps in knowledge.
Other questions for Will? If not, we need a motion. Motion from DT, second from Reverend Emerson. Any question or discussion? All in favor, say aye. All opposed, same sign. That motion carries. And we'll move to exemption to bid inclusion on this item with the Fifth Amendment to the license agreement between the district and First Data Bank, Inc.
And First Data Bank is our leading provider of clinically vetted drug knowledge. And they maintain a massive database associated with information basically on virtually every drug known to man and medication. They provide the knowledge base that includes basic dosing, indications, contraindications, package sizes, all the details associated with the drug, as well as the clinical decision support, the logic associated with drug-to-drug interactions, drug-to-allergy interactions, and so forth. And they provide the detail around the formulary, particularly what items are on what insurance vendors list that are acceptable or not. And there's some education materials that are provided as well. And all of this is integrated within Epic.
All right, heard the presentation. Any questions?
Will, is this a plug-in to Epic?
Yes.
I wouldn't say it's a plug-in. A plug-in assumes that it's easy to connect. This is integrated everywhere within Epic from the clinical perspective. So it's joined at the hip.
Is that a good thing or a bad thing?
It's a good thing because we're leveraging that data throughout all our clinical processes.
Did they have to retrofit any of their technology in order to be able to work on the Epic platform?
No, and we've been leveraging them for quite a few years.
Good. All right, other questions? Need a motion. Motion from Dr. Davis, Second from Reverend Emerson. Any questions or discussion? All in favor say aye. All opposed, same sign. That motion carries. And that will take us to
Thank you.
professional services. Thank you very much, Will. Daphne?
Yep.
Oh, but sorry,
Yep,
with the
the
exemption, understanding that those motions and second included the exemption to bid, and they did. Fantastic. Okay, Daphne.
Thank you, Mr. Chair. This year, our contract for our workers' comp claims management services was coming to an end, so we did go out for bid on that. We are requesting approval of professional services agreement between the hospital district and Sedgwick Claims Management Services, Inc. That is the incumbent, so they actually won the bid on that. They do our claims administration for our workers' comp program. The total cost over a 5-year term would be $884,000.
This is the current vendor then.
It is, but we did go out for bid, so we did have an opportunity to compare them to other vendors.
Good. Any questions for Daphne? We have a motion from Reverend Emerson, second from Dr. Fowler. Any questions or discussion? All in favor say aye. All opposed, same sign. That motion carries too. Thank you, Daphne. And Ms. Ridgway, Washington, welcome. Additional spend for services agreement between the district and Group 1 services. Good to see you, Ashley.
Good afternoon. We're requesting to exercise an exemption to be, not exemption, but an extension, 2-year extension on Group 1, which is our background and licensure check. So we use that to ensure that our contractors, vendors, volunteers have been appropriately screened and are safe to interact with our patients. Again, this is an extension, and we will go to RFP next year at the end, in anticipation of the end of 2-year extension. Total amount we're requesting is $700,000.
All right. Any questions for Ashley?
It says 700,000 additional, that means we have an agreement with them, which you're gonna.
So essentially, we had a 5-year, 3-year with 2 additional years, and so we're exercising those 2 additional years for a total 5. So we want to ensure that we have plenty to be able to spend against over the next. We don't expect, we spend roughly $290 with them a year, so we don't expect to eclipse that, but we don't want to have to come back should we need additional dollars. Say that again. They're a subsidiary of Dallas-Fort Worth Hospital Council. We've used them for some time, and quite frankly, the last time we went to bid, we're the most competitive in terms of service offering as well as pricing per screen.
Do we have a motion? So moved. Motion from Dr. Casey, second from Dr. Fowler. Any question or discussion? All in favor say aye. All opposed, that motion carries. Ashley, thank you, and I'm informed of no need for an executive
No
session
executive session.
today, so thank you all for being here. We are dismissed at 11:19. Thank you for being here.